Welcome to The Debate. Our source material today really brings into sharp focus a critical regulatory paradox that medical examiners face all the time. And that's the inherent conflict between the goals of clinical medicine and the mandate of public safety. Specifically, when we're talking about commercial drivers with diabetes.
And that conflict, it just crystallizes perfectly around one key metric, hemoglobin A1C, or A1C. Clinically, it's the gold standard, right? It tracks your average glucose control over about 3 months. The medical community, the ADA, AAC, they push hard to keep it low to prevent those, catastrophic long-term complications.
Right.
But the DOT, well, the DOT explicitly discounts it as a primary regulatory safety tool. They state it plainly, A1C is not a pass-fail metric.
And that dismissal of A1C is precisely what generates our central question today. Should A1C, this unparalleled measure of long-term metabolic health and, frankly, regimen adherence, be given a greater, more explicit regulatory role, maybe as an automatic trigger for shorter certification intervals in DOT evaluations? I'm going to argue that high A1C levels are a powerful early predictor of functional degradation and inherent instability that the NRCME examiner must formalize into more aggressive, proactive protocols.
And I'll be arguing that the current NRCME focus, which I believe correctly prioritizes severe hypoglycemia and existing functional complications, is the necessary and proper interpretation of the public safety mandate. The DOT's role is to prevent acute, catastrophic failure on the road, and trying to introduce rigid A1C thresholds, well, it risks confusing that regulatory function with the clinical function, and it diverts attention from the single most dangerous outcome, which is sudden incapacitation.
So while the risk of severe hypoglycemia is absolutely the critical immediate safety concern, needing assistance, loss of consciousness, a seizure, and that warrants instant disqualification. A1C provides this crucial evidence of systemic risk that I just don't think we can ignore. The source material validates that clinical guidelines target tight control precisely to prevent that microvascular damage that leads to, retinopathy, nephropathy, and neuropathy.
But those are long-term complications. They're clinical endpoints, not immediate safety risks. They only become disqualifying once they've progressed to the point where they actually impair function. So poor vision, reduced pedal sensation, or muscle weakness that affects safe operation. The standard for certification is current functional capability.
I agree. Function is paramount, but I worry that focusing only on function means we're just waiting for the damage to happen before we react. When an examiner is looking at an A1C that's persistently above 10%, maybe even 12%, they are looking at a clear marker of uncontrolled hyperglycemia. We know that rapidly accelerates that microvascular progression. So if the driver is certified for, say, 12 months, we're basically allowing this physiological damage to just continue unchecked.
But the regulatory framework is built upon functional safety today, not managing metabolic health for the next decade. The NRCME's primary goal is preventing sudden incapacitation. An A1C, as a 90-day average, is just demonstrably ineffective at predicting this. To mandate action based on a high A1C value, it fundamentally shifts the regulatory goal away from acute safety and towards long-term disease management. And that's a role that's reserved for the treating physician.
But my argument is about risk mitigation over the certification period itself. If a driver presents with an A1C of 12%, their metabolic control is, by definition, poor. This driver is not stable. The risk of progression to, say, neuropathy, which disables safe operation, is radically elevated. So I would contend that the risk mitigation goal demands an automatic short-term certification, 1 to 3 months, for all drivers who show an A1C over 10 or 12%, specifically to mandate immediate clinical intervention and demonstrated stability, regardless of their current complication status. That's proactive public safety, not metabolic optimization.
The critical failure of that argument, I think, is that it assumes functional status is somehow independent of this metabolic history. The system already accounts for this progression through the functional assessment tools the examiner has. And focusing on A1C as a hard trigger introduces 2 really significant pitfalls. First, you needlessly penalize functionally safe drivers who just happen to have poor long-term control. And second, and this is more dangerous, it risks obscuring the real safety priority. A driver with a low A1C, let's say 6.0%, who's pursuing overly aggressive control, might be at a high risk for frequent, potentially severe hypoglycemia, the actual sudden incapacitation hazard. We absolutely cannot incentivize low A1C at the expense of stability. Let's delve deeper into that scope. The NRCME is fundamentally a snapshot. It's a point-in-time fitness for duty determination focused on preventing immediate failure. The guidance emphasizes that the examiner's steps correctly prioritize functional safety. For example, during the physical exam, the examiner does sensory testing, maybe using the 10-gram monofilament to identify that peripheral neuropathy that affects pedal sensation. That is functional evidence. The A1C is just a data point in the medical history.
I do appreciate the emphasis on functional assessment, but I have to challenge the notion that the NRCME mandate is only about the exact moment of certification. We're certifying the driver's ability to operate safely for the next 3 or 6 or 12 months. When an A1C is persistently greater than 10%, we are ignoring the clearest, earliest evidence that the driver's underlying pathology is rapidly accelerating toward those exact functional impairments you mentioned. It is physiologically certain they are rapidly progressing toward disqualifying vision loss or neuropathy.
But if we mandated automatic short intervals based purely on A1C, we would be asking the examiner to act as a predictor of pathology rather than an assessor of function. The existing flexibility is a strength. The source material states the examiner may consider a shorter certification for high A1C. This acknowledges the risk of progression without making it a rigid, inflexible cutoff. The regulatory rule has to remain grounded in objective functional metrics, the inability to control the vehicle due to functional loss, or the acute risk of severe hypoglycemia.
But what about the liability? I mean, think about it. If an examiner grants a 6-month certificate to a driver with a 12% A1C, and 3 months later, that driver suffers a vision-related incident because of rapidly advancing retinopathy, didn't the examiner essentially ignore the strongest metabolic evidence of instability? Formalizing a high A1C as an automatic trigger for the shortest interval isn't about treating diabetes. It's about forcing necessary administrative risk mitigation before a predictable functional failure occurs. Why wait for the monofilament test to fail when the A1C tells you that failure's imminent?
Because predicting when that functional failure occurs based purely on A1C is impossible. It just is. Many drivers can maintain adequate function for extended periods despite having poor metabolic control. The system is designed to catch the outcome of poor control, so functional impairment, or acute instability like hypoglycemia, not the abstract state of poor control itself. If we start regulating based on latent probabilistic risks like future neuropathy, where do we stop? Do we start regulating blood pressure based on predicted kidney failure? The line has to be drawn where the risk immediately impacts the ability to operate the vehicle.
Okay, let's pivot to the core dilemma that's highlighted in the literature. Better glucose control reduces long-term harm, but too tight control increases short-term danger. If an A1C is way too high, let's say 11%, the immediate clinical goal shifts from complication prevention to just achieving any stable regimen. From the DOT's perspective, a high A1C suggests a profound lack of treatment adherence or compliance.
And that is the problem. You're conflating poor metabolic control with treatment instability, and that is precisely where the NRCME mandate diverges from the clinical one. The single biggest mistake an examiner can make is using A1C as a simple pass-fail test. For the DOT, hypoglycemia is the absolute top safety priority.
But let me ask you this then. Does an A1C of 11 or 12% indicate a driver whose metabolic pattern is stable and predictable? Or does it indicate someone whose glucose is swinging wildly, maybe running extremely high for long periods, and then interspersed with unmonitored lows? The latter suggests chaos in the regimen, which directly translates to poor compliance and questionable reliability behind the wheel. That instability, not the A1C number itself, is what should trigger the shortest certification.
That is a compelling point about stability, but you have to recognize the risk asymmetry here. We cannot risk encouraging overly tight control in commercial drivers just to meet some A1C target. The driver with an A1C of 6.2% who is experiencing frequent, non-severe hypoglycemic episodes is objectively more dangerous. They are a ticking time bomb for sudden incapacitation than the driver with a stable, albeit high, A1C of 10% who reports zero history of lows and is functionally intact. The NRCME must focus on regulating the acute hazard, which means prioritizing the hypoglycemia history over the 3-month average.
Acknowledging the danger of low A1C leading to hypoglycemia is crucial. I agree. But that danger is managed through aggressive, specific questioning about lows and history of severe episodes. That's the DOT's current mechanism. High A1C is a separate issue. It indicates a fundamental failure of adherence or a non-functioning regimen. If we treat a high A1C, say over 12%, as evidence of unstable control mandating a 3-month interval, we solve the compliance problem. We're not asking the driver to achieve 7%. We are demanding they demonstrate metabolic control stabilization and quickly to prove they can manage the disease while on the road.
But metabolic control is the responsibility of the treating clinician. The examiner's responsibility is compliance with safety standards, and the regulation already accounts for the risk of noncompliance. If the driver can't provide adequate medical documentation or demonstrate functional capability, they're disqualified or certified for a short period. Why introduce a new, potentially misleading metabolic standard when the existing regulatory framework handles noncompliance just fine via documentation and history review?
Because the current system relies too much on examiner discretion, and discretion often fails when time is constrained. We know examiners feel that pressure. The fact that the NRCME explicitly guides examiners to consider shortening the interval for a very high A1C, that shows an inherent recognition of the hazard. My position is that this recognition should be formalized.
I wholeheartedly disagree that formalizing it strengthens the system. The existing structure is robust precisely because it provides flexible regulatory tools tailored to the specific treatment. For insulin-treated drivers, the rules are already highly stringent. They require the MCSA 5870, the Diabetes Mellitus Assessment Form, which has to be completed by the treating clinician. That form, which is mandatory for annual certification, explicitly requires the clinician to report the A1C, the history of lows, and the current status.
That is absolutely correct for insulin-treated drivers, who are already subject to a maximum 12-month certification. But that process doesn't apply to non-insulin-treated drivers who are otherwise medically managed.
Exactly. And that distinction is key. For non-insulin drivers, while they are allowed up to 24 months, examiners are already trained to use their discretion, and they frequently certify them for only 12 months or even shorter precisely because of that disease progression risk, especially when the A1C is high. The existing structure lets the examiner use A1C purely as a stability marker to shorten the interval without making it a rigid, confusing pass-fail metric.
I just think the flexibility argument is weak when we're dealing with these high-risk scenarios. When an A1C is 12%, that driver's condition is by definition unstable from a physiological viewpoint, regardless of whether they're on insulin or metformin. They should be treated identically to a driver explicitly labeled with unstable control in the NRCME guidance, which requires the shortest 1 to 3 months certification for immediate follow-up. This removes subjectivity and ensures that metabolic evidence of rapid deterioration is met with a guaranteed administrative response.
But we have to maintain definitional precision. Unstable control in the regulatory sense usually implies recent significant changes in medication or frequent documented fluctuations leading to severe symptoms. An isolated high A1C absent functional deficits or a severe hypoglycemia history just doesn't meet that threshold for a mandated intervention. We risk overregulating the non-insulin driver who may simply have poor long-term dietary discipline but stable functional capacity, while at the same time drawing the examiner's attention away from the insulin-treated driver who might have a better A1C but a much more dangerous regimen.
Look, the evidence of non-adherence and physiological deterioration posed by a sustained A1C above 10% is a critical factor in determining treatment stability, and treatment stability is a core DOT concern. If the driver cannot maintain a basic level of metabolic control, how can they reliably maintain the complex demands of operating a CMV? This isn't about being an endocrinologist, it's about recognizing a definitive failure of self-management that predicts a future functional failure.
And the current system allows the examiner to demand proof of improved self-management via a short certification, protecting the public while respecting the functional requirements of the job. The flexibility is designed to manage these edge cases and maintain the examiner's focus on the acute safety parameters. We must not allow a metric designed for long-term health to displace the metrics that are essential for immediate safety.
Well, this debate really highlights the persistent and frankly difficult tension between preventing long-term damage and ensuring immediate operational safety. I still maintain that A1C, particularly at very high levels, is the clearest indicator we have of regimen instability and accelerating functional risk, and therefore it warrants elevation from just an informational-only marker to a standardized trigger for the shortest NRCME certification intervals. This formalized response ensures timely intervention and stabilization before predictable, disqualifying complications can emerge on the road.
And our disagreement, I think, centers on that regulatory scope and the primary threat. The DOT mandate is singularly focused on preventing sudden public hazards, which severe hypoglycemia and demonstrable functional deficits capture perfectly. Introducing A1C as a strict cutoff risks misaligning the examiner's focus, potentially encouraging dangerous tight control, and penalizing drivers based on metabolic discipline rather than demonstrated functional safety. The current system, which prioritizes hypoglycemia assessment and functional status, remains the most prudent interpretation of the public safety standard.
A critical discussion for every medical examiner and clinician who is working to bridge that gap between regulatory requirements and clinical best practice.
Indeed, understanding the complex distinction between the goals set for long-term clinical health and those set for immediate public safety is essential for a robust and, I think, a fair medical certification process.